Welcome to the deep dive. Now, if you're gearing up for the AKT or honestly just want to get sharper in those really high stakes areas like GI, hepatology, toxicology, well, this deep dive is absolutely for you.
Mhm.
We've got some pretty dense source material today, the kind designed to really pull out the essential clinical stuff from all the extra noise.
Right.
So our mission isn't just listing facts, it's about mapping out the really high yield things, focusing hard on management steps, those diagnostic links, and crucially, the things that help you decide. Is this urgent or routine? Basically, we want to give you that shortcut to feeling confident clinically and ready for the exam.
Yeah, that focus on strategy is spot on. It's not about rote learning, is it? It's more pattern recognition. Knowing almost instantly, okay, pregnancy constipation means this drug, palliative care means that combination, or spotting an enzyme ratio that just screams alcohol or fatty liver.
Mm,
If you can connect
yeah.
those patterns, you build this kind of mental triage system.
hmm
And that's really the core of safe GP practice, isn't it? So yeah, let's just dive right in.
Okay, let's kick off with something incredibly common in practice. Constipation. Seems straightforward, but the management really does change depending on the context, doesn't it?
Absolutely.
We know the general starting point is always lifestyle, diet,
Mhm.
high fiber, that's the default. But when that doesn't cut it, the prescribing comes in, and context is suddenly everything.
And that's exactly where exams test your safety. Take a pregnant patient with constipation. You have to be, well, pretty restrictive. The sources really hammer home focusing on bulk-forming laxatives,
Mm.
specifically fibogal and methylcellulose.
Right, because they're just mechanical.
Exactly. They just increase water content, add bulk to the stool. That triggers transit naturally without any systemic absorption or, crucially, stimulating the uterus. Very safe profile in pregnancy.
Okay, so contrast that with, say, palliative care. The patient's often frail, maybe not moving much, often on strong opioids.
Mm-hmm.
The goalposts shift completely, don't they?
Totally. Comfort and effect become the priority. Bulk formers just won't cut it, especially with opioids slowing everything down. You usually need a combination, a stimulant to get the bowel moving, like Senna, often paired with a stool softener. You're directly fighting the effects of the opioids.
And what about if it's just opiate-induced constipation? Is there a specific first choice?
Yes, the guidance points towards lactulose first in that specific scenario. Its osmotic action is really reliable, pulls lots of fluid into the colon quite quickly. Very effective for that specific cause.
So taking away the specific context, pregnancy, palliative, opioids, what about just standard chronic constipation? There's a clear pathway there, isn't there?
Oh yeah, a definite ladder. You start with the bulk agent, fibogal. If that's not enough, you bring in the osmotic lactulose. And only if those two haven't worked do you step up to the stimulant, Senna. It's about minimizing reliance on stimulants unless you really need them.
And if that standard three-step plan still isn't working, that's when we're looking at more specialist options, perhaps referral.
Exactly. That's where something like prucalopride comes in. And the mechanism is key here. It's a 5-HT receptor agonist.
Oh,
It
okay.
basically stimulates those receptors to increase peristalsis, get the gut moving more effectively. But yeah, it's reserved for those refractory cases where the standard stuff has failed. Shows you need to know the specialist options too.
Right. Let's switch gears slightly from chronic to acute. Fecal impaction, different ballgame, and the management seems quite age-dependent.
Definitely. For kids with impaction, especially the stool is hard, the sources are really clear. Movicol first. And it's usually an escalating dose regimen to break down that impacted mass.
And for adults, same principle.
Similar principle, yeah.
Yeah.
If the stool is hard, macrogol is the equivalent treatment for adults. Again, using osmotic action to soften and hopefully disimpact safely.
But what if the oral route isn't enough? If the impaction is just too stubborn?
Then you move to rectal interventions. And there's a hierarchy here, which is often tested. You start least invasive, bisacodyl suppository. If that doesn't work, a glycerol suppository. And the final step, if needed, is a phosphate enema. It's a sequence of increasing intervention.
Good to know that order. Now, before we leave laxatives, safety. Beyond just, causing diarrhea, there are a couple of key physiological risks flagged in the sources.
Yeah, you've obviously got to watch out for diarrhea. But the really crucial one, the one that catches people out, is hypokalemia, low potassium.
Why is that such a risk?
Well, significant fluid loss, especially with potent osmotic agents or stimulants, can literally pull electrolytes out with the fluid. Potassium is particularly vulnerable, and low potassium can be dangerous, especially for elderly patients or those with heart conditions. So you need to be vigilant.
Okay, important point. Let's move on to irritable bowel syndrome, IBS, a functional issue, so diagnosis is often about ruling out other things first.
Absolutely. Diagnostic clarity is key.
Hmm.
And the most efficient tool in primary care to rule out inflammatory bowel disease, or IBD, is that fecal calprotectin test. If it comes back normal, that's a massive pointer away from IBD.
So normal calprotectin plus the classic IBS symptoms.
Exactly. Pain that gets better after opening your bowels, maybe worse after eating, that intermittent bloating.
Right.
If you've got that picture and a normal calprotectin, you're pretty confidently on the IBS pathway.
And managing IBS is quite nuanced. Starts with lifestyle and diet again?
Yeah, the basics first. Sensible fluid intake, aiming for about 8 cups a day, limiting caffeine, maybe 2 or 3 cups max. For bloating, things like linseed or oats can sometimes help. But the big dietary intervention now is the low FODME diet.
Ah, yes, that comes up a lot.
It does. It involves systematically cutting down on those fermentable carbohydrates, the ones that gut bacteria feast on and produce gas. It's quite involved, often needs dietitian input, but it's become a cornerstone of management, especially for bloating and diarrhea-predominant IBS.
Okay. And if lifestyle and diet are sorted, but pain is still the main issue?
Then you look at meds. First step is usually antispasmodics, things like Buscopan or Mebeverine. They directly relax the smooth muscle in the gut wall.
Simple enough. But what if they don't work? Refractory pain.
For those really tricky cases, especially if you suspect visceral hypersensitivity where the nerves in the gut are just overly sensitive, the pathway often involves a low-dose tricyclic antidepressant, usually amitriptyline.
Right, using it for its pain-modulating effects, not as an antidepressant per se.
Precisely. It acknowledges that there's often a central nervous system component, a brain-gut axis issue that needs addressing.
Got it. Now, what about IBS, where constipation is the main problem? IBS-C, there's a specific drug mentioned.
Yes, linaclotide, that's quite a specialized agent. It's a guanylate cyclase C agonist.
Wait, how does that work?
It basically ramps up chloride and water secretion into the gut lumen. So it improves transit, softens the stool. But interestingly, it's also thought to reduce visceral pain signaling. So it tackles both constipation and pain in IBS-C.
Sounds useful, but there's a catch, isn't there? A big exam trap.
There is, a major one. You absolutely must not use linaclotide at the same time as Lactulose.
Ah, why is that?
Because you're doubling down on mechanisms that pull massive amounts of fluid into the colon. Lactulose is osmotic, linaclotide boosts secretion. Use them together, and you risk overwhelming fluid shifts, really severe diarrhea, dehydration. It's dangerous and shows a misunderstanding of how they work. Classic exam question.
Right, noted. Don't combine linaclotide and lactulose. And finally, for IBS patients who are still struggling despite everything, diet, meds, what else is there?
This is where the psychological therapies come in. The guidelines specifically mention things like cognitive behavioral therapy, CBT, or hypnotherapy as having good evidence, especially for refractory cases.
Reinforces that brain-gut link again.
Exactly. And just as importantly, the guidelines are clear on what's not routinely indicated, things like acupuncture or reflexology.
Yeah.
While some patients might explore them, they aren't part of the core evidence-based pathway. Stick to the evidence for the exam.
Okay. Moving into territory that demands quick thinking and often urgent action. Red flags. Let's start with hernias. We all know inguinal and femoral, but the AKT often tests the rarer, trickier ones.
Yeah, you need to know the anatomy and the specific risks. Take Richter's hernia. The really scary thing here is that only part of the bowel wall gets trapped in the defect.
So it might not fully obstruct?
Exactly. Strangulation can happen without the classic signs of complete blockage, making it really dangerous because diagnosis can be delayed. Very nasty.
Okay. Then there are ones defined by where they pop out.
Right. Spigelian hernia that comes through the rectus abdominis muscle, often a bit lateral or below the belly button. And the obturator hernia, sometimes called the silent strangler.
Why silent?
It passes through the obturator foramen in the pelvis. It's notoriously difficult to pick up on examination, especially in older, frail, perhaps thin women. They might present with bowel obstruction symptoms, but you can't easily feel the hernia. High index of suspicion needed there.
But let's get to the absolute crunch point for a GP trainee facing the AKT referral urgency. When is it same day? When is it routine? This feels like prime exam territory.
Yeah, it absolutely is. It's a classic trap. Here's the rule. A femoral hernia, always high risk of strangulation because of its narrow neck, needs a same-day referral. No question.
Okay, femoral equals same day.
And an inguinal hernia in a child, also same-day referral.
Right, even inguinal if it's a child.
Yes. The anatomy in kids, plus how quickly they can become unwell with strangulation, makes it an emergency. However, an inguinal hernia in an adult, if it's reducible and not causing obstruction symptoms, is typically a routine referral. That age distinction for inguinal hernias is vital. Nail that one.
Okay, femoral in childhood, inguinal, same day. Adult inguinal, reducible, routine, got it. Let's shift to upper GI bleeds, UJ. Recognizing the high-risk patient starts with the story and the bloods, right?
Definitely. Clinically, you're looking for coffee ground vomit or melena, those black tarry stools. Sometimes it's more subtle, maybe just unexplained iron deficiency anemia, suggesting a slow, chronic bleed.
And the key blood test.
Raised urea. Specifically, urea raised out of proportion to creatinine. It's not just dehydration. It happens because the body digests the blood proteins in the gut, leading to a spike in urea production. That disproportionate rise is a massive clue for an UGIBA.
And if you suspect a peptic ulcer is the cause, the timing of the pain can give you a big hint.
Yeah, it's a useful differentiator. Pain immediately after eating, that tends to suggest a gastric ulcer. Food hits the stomach, stimulates acid, irritates the ulcer straight away.
Makes sense.
Whereas pain that comes on several hours after eating, or maybe wakes them up at night and sometimes feels a bit better after eating, that points more towards a duodenal ulcer. The acid hits the empty duodenum later on.
Useful distinction. Now, the sources mentioned two scoring systems for UGIBA, Rockall and Glasgow-Blatchford. People mix these up.
They do, but they have very different jobs. The Rockall score is mostly used after an endoscopy. It pulls together clinical factors, age, shock, comorbidities, and the endoscopic findings to predict the risk of rebleeding or death. So Rockall post-endoscopy risk of bad outcomes.
Okay. And Glasgow-Blatchford.
That's the pre-endoscopy triage tool. You calculate it based on simple clinical things like hemoglobin, urea, blood pressure, pulse, presence of melena or syncope. It tells you before the scope how likely the patient is to need intervention like transfusion or surgery or admission versus potentially safe outpatient management.
So it helps decide who needs to come in urgently.
Exactly. A Glasgow-Blatchford score of 0, for instance, means a very low risk, and the patient might be suitable for outpatient investigation. Higher scores mean admit now, resuscitate, scope soon. It's all about immediate triage.
Right. Crucial difference. Let's touch on hiatus hernia diagnosis. The investigation depends on how the patient presents.
Yes. If they come in with classic reflex symptoms, heartburn, regurgitation, then an endoscopy is the way to go. You need to see if there's any associated damage like esophagitis or Barrett's esophagus.
But if it's found incidentally, no symptoms.
Then a barium swallow is often used just to visualize the anatomy, see how big the hernia is, what type it is, and don't forget, in a really acute setting, like suspected strangulation or major obstruction, a simple chest x-ray might be the quickest first step you might see an air fluid level behind the heart.
Good point. And finally, in this section, those really ominous signs pointing towards gastric cancer. The nodes mentioned.
Yes, this is classic physical examination stuff, high stakes. You're looking for Troisier's sign that's enlarged lymph nodes in the supraclavicular fossa. Specifically, Virchow's node is the left supraclavicular node.
And finding that means?
It strongly suggests metastatic spread from an abdominal cancer, very commonly gastric cancer. Finding that node is an immediate trigger for an urgent suspected cancer pathway referral. 2-week wait, absolutely.
Okay. And just quickly, the source mentioned esophageal tears too. Borhives versus Mallory-Weiss.
Yeah, important distinction. Borhive syndrome is the really bad one. A full-thickness rupture of the esophagus, usually after forceful vomiting or retching. It's life-threatening, leads to mediastinitis, sepsis, surgical emergency.
Okay.
Mallory-Weiss tear, on the other hand, is also often after retching, but it's a partial mucosal tear at the gastroesophageal junction. Causes hematemesis, yes, but usually less severe, often stops spontaneously. Patient is generally more stable, still needs investigation, but lower acuity than Borhives.
Right. Moving into IBD, inflammatory bowel disease. It's a huge topic, can feel a bit overwhelming. Let's focus on those high-yield shortcuts the source gives us based on age, pain location, and stool type.
These triads are brilliant for quick thinking in exams. Okay, first one. Left iliac fossa pain, LIF pain plus bloody stools in an elderly patient. What does that scream?
That sounds like diverticulitis affecting the sigmoid colon.
Spot on. Now keep the symptoms the same, LIF pain, bloody stools, but change the patient to a young adult.
Ah, okay. Same symptoms. Younger person. That shifts it towards ulcerative colitis, right? Because it often starts discally.
Exactly. Now the third pattern, young person again, LIF pain, but this time the diarrhea is non-bloody.
Non-bloody diarrhea in a young person with LIF pain. That makes me think Crohn's disease because it can be anywhere and isn't always bloody.
Perfect. Those three patterns are your quick sorting hat for the AKT. Okay, let's dig into ulcerative colitis management. First, severity. When do we absolutely need to admit a UC patient?
The threshold is pretty clear. More than 6 bloody stools per day means admission.
Correct. Once they're stable, maintenance therapy depends on how much of the colon is affected.
So if it's just the end bit,
If it's just confined to the rectum, maybe extending slightly into the sigmoid, what we call proctitis or proctosigmoiditis, then rectal mesalazine is the way to go. Topical treatment, fewer systemic side effects.
and if it's the whole colon, canculitis.
Then you need systemic treatment, so oral mesalazine. But, and this is a crucial monitoring point, mesalazine, whether oral or rectal, though less risk with rectal, carries a small risk of interstitial nephritis. So you must check UNEs, especially creatinine, before starting, then usually at 3 months, and then annually.
Okay. Renal function monitoring with mesalazine. Got it.
Yeah.
What about the step-up approach for flares managed in primary care?
It's logical. If it's rectum-only proctitis, you start with rectal mesalazine, give it 4 weeks. If that fails, or if the disease initially involves the rectum and sigmoid, you escalate to high-dose oral mesalazine.
Still trying to avoid steroids as possible.
Exactly. Only if the high-dose oral mesalazine isn't working do you then bring in oral prednisolone, usually a reducing course. It's a systematic escalation.
Yeah.
Local first, then systemic nonsteroidal, then systemic steroid.
Makes sense. And if they're really unwell, in hospital with a severe flare.
They usually get IV steroids first. If there's no significant improvement after about 72 hours, the next step is often cyclosporin. That's a potent immunosuppressant used to try and rescue the colon and avoid surgery in severe steroid-refractory UC.
Right, cyclosporin as the rescue therapy. And what about long-term maintenance if someone keeps flaring?
If a patient has 2 or more flares needing steroids within a year, or if they can't wean off steroids, that's usually the trigger to consider adding an immunomodulator like azathioprine or mercaptopurine, but before starting those.
The safety check, MTPT.
Exactly. Thiopurine methyltransferase enzyme activity testing. Absolutely essential.
Why is that test so critical?
Because a small percentage of people have low or absent MTPT activity. If you give them a standard dose of azathioprine or mercaptopurine, they can't metabolize it properly. The active drug builds up to toxic levels and can cause severe, potentially fatal bone marrow suppression, myelosuppression. So you must check the enzyme level first and adjust the dose accordingly, or choose an alternative agent if they have no activity. Major safety point.
Definitely want to remember. Okay, let's switch to Crohn's disease. Pathologically quite different from UC. What are the key features we should recall?
Crohn's is transmural, goes through the full thickness of the bowel wall. That's why you get complications like fistulae and strictures. Radiologically, think skip lesions, inflamed areas with normal bowel in between. On endoscopy, maybe rose thorn ulcers. Histology often shows granulomas, unlike UC. And on barium studies, you might see the classic Cantor string sign, severe narrowing of the bowel lumen.
Gallstones are also mentioned as an association.
Yes, due to impaired bile salt absorption in the terminal ileum, which is often affected in Crohn's.
Okay. Management-wise, it depends on location and severity again.
It does. For perianal Crohn's fistulas, abscesses near the back passage, metronidazole is often the first-line antibiotic choice. For inducing remission in mild to moderate flares, oral steroids are the mainstay.
And for maintaining remission, preventing flares.
This is where it differs slightly from UC guidance sometimes. The source actually lists oral steroids as first line for inducing remission. Maybe mesalazine is a less effective option for maintaining it in some cases. But more typically for maintenance, especially after steroid induction or for recurrent disease, we move to those immunomodulators. Azathioprine or mercaptopurine, after MTPT testing, of course, or methotrexate.
And for the really severe or complicated cases, fistulizing disease.
That's where the biologics come in, particularly the anti-TNF agents like infliximab or adalimumab. They are very effective for severe refractory Crohn's and are often the best option for healing fistulae.
Okay. And the single most important piece of lifestyle advice for any Crohn's patient?
Stop smoking. Simple as that. The evidence is overwhelming. Smoking significantly worsens Crohn's disease activity, increases flare frequency, increases the need for surgery, makes treatments less effective. It's absolutely non-negotiable advice.
Crystal clear. Let's wrap this section with gastroenteritis. Most cases are just fluids and rest, but we need to know when to treat specific bugs and spot the red flags.
Right. Standard traveler's diarrhea, often E. coli, usually self-limiting. Azithromycin might be considered if it's severe or in a high-risk person, but often not needed. However, E. coli in a child, that's different.
Why? What's the concern there?
Specifically, the Shiga toxin-producing strains, like E. coli 0157, if a child has bloody diarrhea, maybe vomiting, and then stops passing urine, you have to think, Hemolytic uremic syndrome, HUS, that's a medical emergency, needs immediate referral, causes acute kidney injury, anemia, low platelets. Very serious.
Okay, E. coli plus no urine output in a child, immediate referral. What about other bugs causing bloody stools?
Salmonella, often from poultry or eggs, can cause bloody stools, sometimes a fever, occasionally a rash. If treatment is needed, it's usually ciprofloxacin. For more chronic or severe bloody diarrhea, especially with travel history, think omebiasis or Shigella. Both are typically treated with metronidazole.
And the bug with that notorious neurological association?
Campylobacter, very common, usually from undercooked chicken, causes quite nasty diarrhea. If antibiotics are needed, it's often clarithromycin or azithromycin. But the crucial link to remember for exams is Guillain-Barré syndrome, GBS. A small proportion of people develop this post-infectious ascending paralysis weeks after Campylobacter infection.
Important association. And just quickly, the commonest causes overall.
In adults, it's norovirus, the winter vomiting bug,
Oh.
highly infectious. In young children, historically rotavirus was the commonest, though vaccination has reduced its impact significantly.
Right. Now, let's nail the C. difficile management protocol, especially for recurrence. This seems like a perfect step-by-step process for exams.
It is. Okay, initial episode of C. diff infection. First-line treatment is oral vancomycin for 10 days.
Simple enough, but it often comes back. What if it recurs within, say, 3 months?
If the recurrence happens less than 3 months after the initial episode finished, you switch agents. You use fidaxomicin.
Why fidaxomicin?
It's thought to have a lower rate of subsequent recurrence compared to repeated vancomycin, possibly because it's more targeted and might spare more of the normal gut flora. So, recurrence 3 months? Fidaxomicin.
Okay, but what if the recurrence happens later than 3 months?
If it's more than 3 months since the last episode, the thinking is it might be a new infection or a very late relapse, so you can go back to the initial agent. Treat again with oral vancomycin for 10 days.
Right. So vancomycin recurrence 3 meters, fidaxomicin, vancomycin ichor recurrence 3 meter, vancomycin again. What if it happens again? Multiple recurrences.
If a patient has had 2 or more recurrences, so at least 3 episodes in total, or if the infection is proving really difficult to clear refractory, that's the trigger to consider fecal microbiota transplantation, or FMT.
A fecal transplant.
Yep. The aim is to repopulate the gut with healthy bacteria to outcompete the C. Diff has become a key treatment for recurrent or refractory infection. That's sequential protocol, then ACT, then FIDAX or FANC, depending on timing. Then FMT is definitely high yield.
Okay, moving into the liver. Hepatology. Interpreting those liver function tests, LFTs, is fundamental, especially the enzyme patterns, right? The ratios can give you a big clue straight away.
Absolutely. This is one of those golden rules. If you see alcoholic liver disease, the pattern is typically AST being significantly higher than ALT. The AST-ALT ratio is usually greater than 2.
AST higher than ALT ratio 2 is think alcohol. Why is that?
The theory is that alcohol causes more damage to the mitochondria within liver cells, and AST is found in mitochondria as well as the cytoplasm, whereas ALT is mainly cytoplasmic. So more mitochondrial damage releases disproportionately more AST.
Okay, interesting. Now contrast that with the other really common cause of abnormal LFTs these days, non-alcoholic fatty liver disease, NASLD.
In AFLD, it's usually the other way around. ALT is typically higher than AST. The ALT-AST ratio is often greater than, well, sometimes quoted as greater than 1, but often significantly higher, maybe even 3 or more in some cases.
So ALT-AST points more towards NAFLD. And if you suspect NAFLD, what's the next step?
The focus then shifts to figuring out the degree of liver fibrosis or scarring, because that's what determines prognosis. You don't want to biopsy everyone. So we use non-invasive tests. That might be blood tests like the ELF test, enhanced liver fibrosis, or calculated scores like the FIB4 index or the NAFLD fibrosis score, which use standard blood results like ALT, AST, platelet count, age, albumin, etc., to estimate the fibrosis risk.
Right, non-invasive fibrosis assessment. We also need to be really aware of drug-induced liver injury, DILI. Lots of common drugs can upset the liver.
Huge issue. You can get different patterns. Hepatocellular injury means the liver cells themselves are damaged, so you see raised ALT and AST. Classic culprit is paracetamol overdose causes massive rises. Statins can cause milder rises. Some TB drugs like rifampicin and pyrazinamide too.
Okay, that's hepatocellular. What about cholestatic injury?
Cholestatic means bile flow is blocked or impaired. So the key enzyme that rises is alkaline phosphatase, ALP, often with GGT. Bilirubin might rise too. Think antibiotics. Comoxiclav is notorious for this, flucloxacillin too. Even the oral contraceptive pill can sometimes cause cholestasis.
And some drugs cause long-term damage. actual cirrhosis?
Yes, unfortunately. Chronic use of methotrexate requires careful liver monitoring for fibrosis risk. Amiodarone is another one. Methyldopa, an older antihypertensive, can also cause chronic liver issues. Always worth checking the BNF if LFTs go off with a new drug.
Definitely. Let's focus now on decompensated liver disease. This is when the liver is really failing, often due to advanced alcohol damage or maybe chronic viral hepatitis. What does the LFT pattern show then? We mentioned AST-ALT ratio for alcohol, but what about function?
Yeah, in decompensation, it's not just the enzymes, it's the liver's synthetic function failing. So you see things the liver makes going wrong. The prothrombin time, PT and INR, will be high because the liver isn't making clotting factors properly.
So easy bruising or bleeding.
Exactly. And albumin levels will be low because albumin is made in the liver. So low albumin contributes to things like ascites and peripheral edema. Clinically, they will often be jaundiced, might have ascites, maybe spider naivety, palmar erythema, the classic signs.
And the complications of decompensation are life-threatening. Management needs to be swift and protocol-driven. Let's take hepatic encephalopathy first. Confusion, reduced GCS.
Yeah, this happens because the failing liver can't clear ammonia from the gut. Ammonia builds up, gets to the brain, causes confusion, drowsiness, eventually coma. The absolute cornerstone of treatment is lactulose.
Lactulose again, how does it work here?
It works differently than in constipation. In the colon, bacteria break down lactulose into acids. This lowers the colon's pH. The acidic environment can convert ammonia, NH3, into ammonium ions, NH4+. Ammonium ions are charged, so they can't easily cross back into the bloodstream. They get trapped in the colon and excreted. It effectively pulls ammonia out of the system. Rifaximin, an antibiotic, is often added too.
Clever mechanism. Okay, next complication. Spontaneous bacterial peritonitis, SBP, infection in the acidic fluid.
Very common, very dangerous. Presence often subtly, maybe just a fever, abdominal pain, feeling unwell in someone with known ascites. Diagnosis is confirmed by sampling the acidic fluid, paracentesis, and finding a high neutrophil count. Acute treatment is broad-spectrum IV antibiotics, like cefotaxime.
And the key point for primary care, especially after they've had an episode.
Prophylaxis. Once someone has had an episode of SBP, their risk of recurrence is very high. So they need long-term prophylactic antibiotics, often ciprofloxacin daily, to prevent it happening again.
Right, secondary prophylaxis for SBP is key. What about varicose bleeding? Massive hematemesis.
Absolute emergency. This is from high pressure in the portal vein, portal hypertension, causing veins in the esophagus or stomach to swell up like varicose veins and then rupture. Management starts with ABCDE, resuscitation, then urgently give terlipressin.
Terlipressin?
Yes, it's a vasopressin analog. It causes vasoconstriction in the splanchnic circulation, the gut's blood supply. This reduces blood flow into the portal system, lowers the pressure, and helps stop the bleeding from the varices. Buys time to get to endoscopy.
And at endoscopy.
They do endoscopic variceal band ligation, put tiny elastic bands around the bleeding varices to stop the flow. After the acute bleed is controlled and they're stable, they need prophylaxis to prevent rebleeding. That's usually with a non-selective beta blocker, typically propranolol.
Propranolol to lower portal pressure long term. Got it. And finally, just managing the ascites itself, the fluid buildup.
The mainstay diuretic here is spironolactone. It's an aldosterone antagonist. Aldosterone contributes to fluid retention and liver disease, so spironolactone counters that. Often started at 100 milligrams, might go up to 200 milligrams or even 400 milligrams. Sometimes a loop diuretic like furosemide is added if spironolactone alone isn't enough. Sodium restriction is vital too.
Okay, comprehensive overview of decompensation. Let's finish hepatology by quickly differentiating 3 specific syndromes presenting with jaundice. It's all about matching the pattern: symptoms, associations, antibodies.
Right, the diagnostic triads. First, primary sclerosing cholangitis, PSC. The absolute key things to link are jaundice, severe itching, pruritus, and a background diagnosis of ulcerative colitis. About 70–80% of PSC patients have UC.
So jaundice plus itching plus UC, think PSC, what is it?
It's inflammation and scarring of the bile ducts, both inside and outside the liver. Leads to blockages, cholestasis. Management often involves managing the itching, maybe with cholestyramine. And crucially, PSC carries a very high risk of developing cholangiocarcinoma, bile duct cancer. Needs surveillance.
Okay. Second syndrome, primary biliary cirrhosis, or PBC, actually now called primary biliary cholangitis.
Yes, PBC. Different profile. Think middle-aged women. Key symptom, again, is often pruritus, maybe fatigue. Labs show a cholestatic picture, high ALP. But the specific markers are raised: IgM antibodies and classically positive antimitochondrial antibodies, AMA.
AMA positive strongly suggests PBC treatment.
The main treatment is ursodeoxycholic acid, UDCA. It's a bile acid that helps improve bile flow and can slow disease progression.
Okay. And the third one, the benign hereditary one, Gilbert syndrome.
Gilbert's, very common, totally benign, presents as mild jaundice, often noticed only when someone is stressed, unwell with a virus, fasting, or after strenuous exercise.
And the labs are key to diagnosis.
Absolutely key. You see only a raised unconjugated bilirubin. All the other LFTs, ALT, AST, ALP, albumin are completely normal. And importantly, the reticulocyte count is normal, ruling out hemolysis as the cause of the raised bilirubin. It's just a partial deficiency of the UGT enzyme needed to conjugate bilirubin. Reassurance is the only management needed.
Right. As you said earlier, GI problems often have ripples throughout the body. Let's look at celiac disease. It's way more than just diarrhea, isn't it? It's a systemic thing due to malabsorption.
Totally systemic. The damage to the small bowel lining messes up absorption of pretty much everything. So you classically see deficiencies. Iron deficiency is common. Vitamin B12 can be low. But folate deficiency is actually often more common or severe because folate is mainly absorbed in the proximal small bowel, which gets hit hardest in celiac disease.
Okay, low iron, B12, and especially folate. What about other systemic effects?
Well, the chronic diarrhea itself can be debilitating, sometimes with secondary lactose intolerance due to the damaged villi. Then you get effects from nutrient deficiencies. Osteoporosis or osteomalacia from poor calcium and vitamin D absorption. Fertility problems, recurrent miscarriage can be linked. General fatigue, weight loss. It's multi-system.
And like other chronic inflammatory conditions, there are increased cancer risks.
Yes, unfortunately. Celiac disease carries an increased risk of certain cancers, particularly enteropathy-associated T-cell lymphoma, EATL, which is a type of non-Hodgkin lymphoma affecting the small bowel, and also a slightly increased risk of small bowel adenocarcinoma and possibly esophageal cancer.
Wow, okay. And there's something about hyposplenism too, needing a vaccine.
Yes, that's an important point. Many people with long-standing or poorly controlled celiac disease develop functional hyposplenism. The spleen doesn't work properly, even at its normal size. This makes them more vulnerable to infection with encapsulated bacteria, like pneumococcus.
Ah, so like patients without a spleen.
Exactly the same risk profile. That's why guidelines recommend they have the pneumococcal vaccine, usually repeated every 5 years. It's a key management point, often missed.
Good tip. Now, the testing pathway for celiac disease, it's sequential, but the most important first step is often forgotten.
The absolute crucial first step is ensuring the patient is eating gluten before you test them. They need to be consuming gluten regularly, in more than one meal a day, for at least 6 weeks prior to the blood tests. Otherwise, the antibody test could be falsely negative.
Right, gluten challenge first, then the blood test.
You start with the IgA tissue transglutaminase antibody, IgA-TTG. That's the best screening test. If someone is known to be IgA deficient, which can happen, you check IgG-TTG instead. If the TTG is positive, often total IgA is checked too, and then you might also check IgA endomysial antibodies, EMA, which are very specific but less sensitive.
But the blood tests aren't the final word.
No. While strongly positive antibodies in the right clinical context are highly suggestive, the gold standard for diagnosis remains an endoscopic biopsy of the duodenum or proximal small bowel. You're looking for the characteristic histological features: villus atrophy, crypthyperplasia, increased intraepithelial lymphocytes.
And that skin condition associated with celiac.
Ah, yes, dermatitis herpetiformis. Had intensely itchy, blistering rash, often on elbows, knees, buttocks. It's essentially celiac disease of the skin. Diagnosis is often by skin biopsy, looking for IgA deposits. Treatment involves a strict gluten-free diet, same as celiac, and the drug dapsone can provide rapid symptom relief for the rash itself.
Okay, comprehensive look at celiac. Let's move to B12 deficiency. What's the most common reason we see this in the UK?
By far the most common cause here is pernicious anemia.
And that's an autoimmune thing.
Yes, exactly. It's autoimmune destruction of the parietal cells in the stomach lining. These cells normally produce intrinsic factor, which is essential for absorbing vitamin B12 in the terminal ileum. No intrinsic factor, no B12 absorption.
So what are the classic clinical features?
Well, you get the symptoms of anemia, tiredness, lethargy, shortness of breath, pallor. Because B12 is needed for cell division, you get a macrocytic anemia, sometimes called megaloblastic anemia, with large red blood cells. But the really crucial distinguishing feature of B12 deficiency is the potential for neurological symptoms.
Ah, yes, the nerve damage.
Right. Pins and needles, paresthesia, numbness, unsteadiness or gait problems, ataxia, potentially even memory problems or mood changes. This is due to demyelination in the spinal cord and peripheral nerves. It's vital to treat B12 deficiency promptly to prevent irreversible neurological damage.
And because pernicious anemia is autoimmune, it often hangs around with other autoimmune conditions.
Very much so. There's a strong association with other organ-specific autoimmune diseases. Think Hashimoto's thyroiditis, type 1 diabetes, vitiligo, Addison's disease, even celiac disease sometimes, worth screening for symptoms if one is diagnosed.
And treatment is straightforward.
Usually. Because the absorption mechanism is broken, oral B12 often isn't effective for pernicious anemia. So treatment is with intramuscular hydroxycobalamin injections. Initially loading doses, then maintenance injections typically every 3 months for life.
Okay, lifelong injections for PA. Now let's compare two genetic liver diseases involving metal overload. Hemochromatosis, that's iron overload.
Yes, hereditary hemochromatosis. It's an autosomal recessive condition causing excessive iron absorption from the diet. The iron then gets deposited in various organs, causing damage.
What are the classic symptoms or signs?
It's often picked up incidentally on blood tests, but clinically, think bronze diabetes, skin pigmentation plus diabetes mellitus, chronic fatigue, tired all the time, TATT, joint pain, particularly arthritis in the hands, especially second and third MCP joints, erectile dysfunction or loss of libido due to pituitary iron deposition, cardiomyopathy leading to heart failure, liver cirrhosis, and increased risk of hepatocellular cancer.
Quite a list. And the blood tests for iron studies show a specific pattern.
Yes, the classic iron overload pattern. You see a massively raised ferritin level indicating high iron stores. Transferrin saturation will be very high, often over 50 or 60%, because the iron transport protein is overloaded. And critically, the total iron binding capacity, TIBC, is usually low or normal because there's no spare capacity to bind more iron. Genetic testing confirms the HFE gene mutation.
High ferritin, high saturation, low TIBC. Got it. Treatment.
Mainstay of treatment is removing the excess iron. That's done primarily by therapeutic venesection, basically. Regular bloodletting, like donating blood, but more frequently initially. The goal is to get the ferritin levels down to a safe range. If venesection isn't possible or tolerated, iron chelation therapy with drugs like dysferrioxamine can be used.
Okay, venesection for iron overload. Now, Wilson's disease, that's copper overload, right? Different metal, different pattern.
Correct. Wilson's disease is also autosomal recessive, but it's a defect in copper excretion into bile. So copper accumulates mainly in the liver, brain, and eyes.
How does it typically present?
Often presents younger than hemochromatosis, maybe in adolescence or early adulthood. Can present with liver disease, anything from asymptomatic LFT rises to acute liver failure or chronic cirrhosis. Or it can present with neurological symptoms, tremor, clumsiness, slurred speech, dysarthria, Parkinsonism-like features, or psychiatric disturbance, depression, psychosis.
And the specific eye sign.
The Kaiser-Fleischer rings. Greenish-brown copper deposits in the cornea, seen on slit lamp examination. Diagnostic if present, along with neurological signs.
Lab tests for Wilson's.
It's usually the opposite of what you might expect. Serum copper might be low, normal, or high, but the key is usually low serum ceruloplasmin, that's the main copper-carrying protein, and it's often reduced. And crucially, urinary copper excretion is high, especially after a penicillamine challenge. Liver biopsy can also measure copper content.
Low ceruloplasmin, high urinary copper. Treatment.
Treatment involves lifelong copper chelation therapy to remove excess copper and prevent reaccumulation. Drugs used include penicillamine or trientine hydrochloride. Zinc salts can also be used as they block intestinal copper absorption.
Okay, and finally, just to really nail the iron studies pattern, let's contrast hemochromatosis again with simple iron deficiency anemia.
Yes, it's the perfect inverse relationship. What's essential to know? In hemochromatosis, ferritin is HEH, transferrin saturation is HEH, TIBC is low W. In iron deficiency anemia, ferritin is low, stores are depleted, transferrin saturation is low, not much iron around to transport, but the TIBC is high GH. The body makes more transferrin, trying to scavenge for any available iron, so the binding capacity goes up.
Low ferritin, low saturation, high TIBC for iron deficiency. Perfect contrast. Okay, final section, rapid fire, toxicology, overdoses. In an emergency or in the exam, you need the link. Substance TEP, key features, antidote, seconds count, let's go. Salicylate overdose aspirin.
Key features: tinnitus, nausea, hyperventilation leading to a respiratory alkalosis initially, then shifting to a severe metabolic acidosis, confusion, coma, antidote management. Sodium bicarbonate. It alkalinizes the urine, which traps the salicylate ions in the tubules and drastically increases renal excretion. Severe cases need hemodialysis.
Okay, bicarb for aspirin OD. Next, benzodiazepine overdose. Sleeping pills, anxiety meds.
Presentation: sedation, respiratory depression, slurred speech, ataxia. Antidote, flumazenil. It's a competitive antagonist of the benzodiazepine receptor site on the GABA complex. Reverses sedation quickly. Caution. Can precipitate seizures in people chronically dependent on benzos or with co-ingested proconvulsant drugs.
Flumazenil for benzos, opiate overdose, heroin, morphine, codeine, etc.
Classic triad. Pinpoint pupils, meiosis, respiratory depression, slow, shallow breathing, reduced Glasgow Coma Scale, GCS. Yawning can sometimes be seen before respiratory failure. Antidote, naloxone, pure opioid receptor antagonist. Works very fast, 5V, short half-life, so might need repeated doses or an infusion. For long-term addiction treatment, naltrexone is an oral option.
Naloxone for acute opiate OD, warfarin overdose, the anticoagulant.
Depends on INR level and bleeding. If actively bleeding or needs emergency surgery, immediate reversal with prothrombin complex concentrate, PCC, gives the vitamin K-dependent clotting factors directly, plus Aubrey vitamin K, which takes longer to work but provides sustained reversal as the PCC wears off. If INR high but no bleeding, oral vitamin K might suffice.
PCC plus VitK for warfarin bleed. What about the newer anticoagulants, the DOACs, like apixaban, rivaroxaban, the factor XA inhibitors?
Specific reversal agents are now available. The source mentions andexanet alpha. It acts like a factor XA decoy, binding up the drug molecule so they can't inhibit the actual factor XA in the clotting cascade. Very useful in major bleeding. For dabigatran, a direct thrombin inhibitor, the reversal agent is idarucizumab.
Andexanet alpha for Xyris inhibitors, digoxin poisoning heart medication.
Can cause nausea, vomiting, confusion, visual disturbances, yellow halos, and various arrhythmias, especially bradycardia and heart block. Antidote, digoxin-specific antibody fragments, often called digifab or digibind. They bind circulating digoxin, neutralizing it and allowing renal excretion. Life-saving in severe toxicity.
Digifab for digoxin, lithium overdose mood stabilizer.
Toxicity depends on the level and whether it's acute or chronic. Mild symptoms. Nausea, tremor, maybe diarrhea, severe. Seizures, profound confusion, coma, kidney failure, management. Mild cases often just need supportive care, lots of IV fluids to encourage renal excretion. Lithium is cleared by the kidneys. But severe poisoning, or if renal function is poor, requires hemodialysis. Dialysis is very effective at removing lithium.
Fluids for mild, dialysis for severe lithium OD. Last one, beta blocker poisoning, propranolol, bisoprolol, etc.
Causes profound bradycardia, slow heart rate, and hypotension, low blood pressure, potentially cardiogenic shock. Can also cause bronchospasm, hypoglycemia. Initial management, 4V fluids, atropine for the bradycardia. But often, especially in large overdoses, they are resistant to atropine.
So if atropine doesn't work,
The specific antidote is high-dose glucagon. Glucagon works by bypassing the blocked beta receptors. It activates adenyl cyclase directly within heart muscle cells, increasing intracellular cyclic AMP. This boosts heart rate and contractility, even when beta receptors are blocked. It's the key treatment for refractory beta blocker and calcium channel blocker overdose. #tag outro. So we've covered a lot of ground there, from common constipation pathways right through to emergency toxicology. If there's one takeaway message, I think it's really about seeing the connections, the patterns, like that C. diff protocol, vancomycin first. But if it recurs quickly, under 3 months, you switch to fedexomycin. If it's later, you can use vancomycin again. Then maybe FMT. It's sequential logic.
yeah, that C-div algorithm is a perfect example.
Or in hepatology, how the AST-ALT ratio gives you that instant clue. Is it likely alcohol or more likely fatty liver? Or in a patient with LIF, pain and diarrhea, just knowing their age and whether there's blood instantly points you toward diverticulitis or UC or Crohn's. It's that pattern recognition that makes the difference, especially under pressure in the AKT.
Absolutely. That pattern recognition is gold. And the safety checks, too, like the linaclotide lactulose no-go, or remembering the MTPT test before azatioprine. Those details aren't just for exams, they're fundamental to safe prescribing day-to-day.
Spot on. It's about building that framework in your mind, linking the presentation, the key investigations, the management steps, the safety nets. That's what turns knowledge into clinical competence.
Right. Which leads us nicely into our final provocative thought for you, the listener, to ponder. We touched on biliary atresia, that neonatal condition where bile ducts are blocked from birth. It causes jaundice, an enlarged liver and spleen, that often, surprisingly, pale or normal-colored stools initially because bile simply can't get out. Now, considering that, what other common but potentially urgent cause of persistent jaundice in a neonate absolutely must be excluded, especially thinking about conjugated versus unconjugated bilirubin? And taking it broader, how does that fundamental concept of bile flow, or the lack of it, actually link the underlying pathology of biliary atresia in newborns, primary sclerosing cholangitis, often with UC, and primary biliary cholangitis, the autoimmune one in adults? They have totally different causes, but what's the shared problem at the core? Something to mull over regarding the liver's plumbing.
Good question.
Thank you for joining us for this deep dive into GI, hepatology, and toxicology essentials. Hopefully that's armed you with some high-yield patterns and pathways for the AKT and beyond. We'll catch you next time for another deep dive.